Good morning, everybody. Welcome to Pediatric Grand Rounds. This is the Chard Lectureship, and I'm Suzanne Meza, Director of CME here at Seattle Children's. And from here, I will turn things over to Dr. Hawkins to introduce our speaker and talk a little bit about the Chard Lectureship. Thanks, everybody.
Thank you, Susan. I want to thank everyone for being here today. This is a great opportunity to remember the legacy of Dr. Ronald Chard, or Chard as we knew him. This is the 18th lecture, but the first time we've done it virtually, but it's a great opportunity to remember him. This is what the hospital used to look like when Chard worked here. It doesn't look like this anymore. There have been several more buildings that have gone up, but Chard had a profound impact over a very long period on this hospital's history and in pediatric oncology in general. Chard spent his entire academic career in Seattle. He went to medical school at the University of Washington and was a resident fellow and a physician here for his entire career. He was very active in the Children's Cancer Group, which is one of the 4 groups that preceded COG. But he also had a profound impact on the training of pediatric oncology fellows, with over 80 fellows receiving their training here in Seattle and continuing to practice all around the world. When Chard started, the outcome for childhood leukemia was really quite poor. But by the time he retired in the late 90s, we had seen a dramatic improvement in the overall survival for childhood leukemia. But you'll notice that this slide stops at 5 years from diagnosis. We talk about 5-year survival rates. And although we're very proud that that's gone up so high compared to the pre-Chard time, what you're going to hear about today is what about the years after that? And I think Chard would be very proud to know that we're focusing on how can we minimize some of the long-term side effects of the children who are being cured with the current therapies that were developed during his era. Chard was somebody who didn't write very many papers, was very involved in clinical trials, but really brought a different perspective. He had such a mastery of pediatric oncology, and he used his knowledge to inform how we design studies. And he often felt that it was his personal experience and the experience that we have as physicians that is actually much more important, much more valuable than what we can learn from clinical trials, or at least we should inform our clinical trial design from what we experience as physicians. And he certainly brought that into the care he provided, as well as the studies he oversaw. So this is a great opportunity to remember Dr. Chard, who was a great Cougar fan. I think you'd be very proud of the speaker we had this year, and Scott Baker will introduce her.
Oh, thanks, Doug. It was great. So it's my pleasure to introduce Dr. Bhatia today. So Dr. Bhatia comes to us today from her office at the University of Alabama in Birmingham, the School of Medicine, since we learned last night that Hurricane Zeta knocked her power and hence her internet out. Smith is a professor in the Department of Pediatrics in the Division of Hematology and Oncology, and she holds the Gay and Bu White Endowed Chair in Pediatric Oncology. Dr. Bhatia did her initial medical training and pediatrics residency at the All India Institute of Medical Sciences in New Delhi, and subsequently came to the U.S. and to the University of Minnesota, where she did her pediatric hematology oncology fellowship, and where she stayed on as a postdoctoral fellow and completed an MPH, and also where she developed her interests in cancer survivorship. Smith then moved to the City of Hope, where she spent the next 18 years of her career and where she became the chair of the Department of Population Sciences. In 2015, Smith moved to the University of Alabama, where she is the vice chair for outcomes research in the Department of Pediatrics, director of the Institute for Cancer Outcomes and Survivorship, and the associate director of the Center for Outcomes and Effectiveness Research. Dr. Bhatia is really an international leader in pediatric oncology and outcomes and survivorship research. Her work in establishing the bone marrow transplant survivor study that was initially funded by the NCI in 2000 has really provided a knowledge base for a large part of what we know today about transplant survivorship. She's also a leader in non-transplant cancer survivorship and has made important discoveries in the mechanisms of anthracycline-related cardiotoxicity and in outcomes disparities and medication adherence. This really just scratches the surface in terms of Dr. Bhatia's overall accomplishments and leadership roles that she's held, but I need to stop now and leave her some time for her lecture today, which is titled The Science of Surviving Cancer, Predicting and Preventing Cancer-Related Morbidity. With that, welcome, Smita.
Thank you so much, Scott. And I really want to thank everybody for this invitation to the Chard Lectureship. I'm honored. As Scott said, today the topic of my conversation with you is on the science of surviving cancer. And what I want to share with you is where we are in terms of predicting and preventing cancer-related morbidity. So just first of all, of course, I have no disclosures to declare. First of all, just to lay the groundwork in terms of what is the burden of long-term morbidity in childhood cancer survivors, I draw upon here the Childhood Cancer Survivor Study findings, where in 2006, Kevin Effinger made a landmark publication where he showed that those who survived 30 years, about 40% or more of them suffered from severe life-threatening or fatal chronic health conditions. And what were those conditions? Those were steroid-related osteonecrosis, anthracycline-related heart failure, and then radiation-related second cancers. These chronic health conditions also had an effect on late mortality. And so in this slide, this is out of the British Childhood Cancer Survivor Study. I show you the baseline cumulative mortality in the general population. And on the x-axis is the age, the time. And then what you see is that for recurrence-related mortality, there's an initial rise, but then it sort of plateaus out. On the other hand, for other health-related causes of mortality, the incidence continues to climb and crosses over that due to recurrence-related mortality. Our childhood cancer survivors are at a six-fold higher risk of dying, and their life is shortened by about 1 to 2 decades. We also know through a variety of large studies that there are clearly different associations between therapeutic exposures and chronic health conditions. So here I show you the relationship between steroids and radiation and osteonecrosis, alkylating agents and pelvic radiation and hypogonadism, anthracyclines and chest radiation and heart. There are obviously a variety of therapeutic exposures that are introduced, and these inevitably often result in adverse events. The magnitude of the adverse events and the prevalence of the adverse events is modified by the age of exposure and also sex. But there are other mediating factors, such as genetic predisposition, lifestyle exposures, and viral infections. And all of these can potentially be used to identify those who are at the highest risk, such that we can modify therapeutic exposures in future generations. Summarize the therapeutic exposures for cases and controls. We also ask for source documentation, and these are the key adverse events that we are looking at. We're looking at osteonecrosis, cardiomyopathy, subsequent neoplasms, and stroke. And I'm today going to discuss cardiomyopathy and subsequent neoplasms. So, cardiomyopathy in our childhood cancer survivors, the primary risk factor is anthracycline chemotherapy. Risk modifiers include chest radiation, younger age at exposure, female sex, and cardiovascular risk factors. Prognosis is unfortunately poor. 5 years after diagnosis of congestive heart failure, the survival rate is less than 50%. Now, in this particular study, what we wanted to do was to, in addition to look at genetic risk factors, identify or really define the dose-response relationship between anthracycline exposure, shown here on the x-axis, and the risk of developing heart failure, and adjusting for a variety of factors. And here, what you see is an inflection point that those who have received 250 milligrams per meter squared or higher are at a much higher risk of developing heart failure. But there is evidence of inter-individual variability in the risk of anthracycline-related heart failure. So here I'm showing you the cases, and each green dot represents a case. On the y-axis is the dose of anthracyclines, and when you cut the dose at 250 milligrams per meter squared, you see that several individuals have developed heart failure at lower doses of anthracyclines. On the other hand, amongst those who are anthracycline exposed childhood cancer survivors, you cut the dose at 250 milligrams per meter, that several have escaped the development of heart failure. And this begs the question for role of genetic susceptibility. So this is how we framed our question on the pathogenesis of cardiomyopathy. We said that upon higher doses of anthracyclines, there is a need for drug transport for transfer of the anthracyclines into the cell or the cardiomyocyte. This results in a reduction of the anthracyclines using the NADPH oxidase multi-enzyme complex, or a reduction by the attachment of an alcohol moiety, which by itself results in myocyte apoptosis. But both the alcohol moiety and the reduced doxorubicin complex results in a higher reactive oxygen species, mitochondrial dysfunction, and then myocyte apoptosis, resulting in maladaptive LV remodeling, and finally heart failure. We used a candidate gene approach, a carefully curated SNP array, agnostic genome-wide association studies, and then some functional studies in order to see how we could explore this particular framework. Looking at the candidate gene approach, we targeted carbonyl reductase gene. And the reason for doing this is that it is expressed in the heart and it is fairly frequent, both in whites and Black populations. And what happens is that when you have a doxorubicin moiety, carbonyl reductase, as I had mentioned earlier, results in a 2-electron reduction, resulting in an addition of an alcohol moiety and formation of doxorubicinol, which is fairly cardiotoxic, much more than the parent drug, and also hangs around in the cardiomyocyte for a much longer period of time. These were the demographic characteristics of our patient population: 170 cases, 317 matched controls. These were, the patients were diagnosed at a median age of about 7 years, and they were about 16 to 18 years at study participation. About 73%, 75% were non-Hispanic whites. Clinical characteristics of the cases and controls: as I'd mentioned, we matched them on primary cancer diagnosis. So we had lymphoma, bone tumors, and sarcoma, ALL, AML, and a smattering of other diagnoses. And the median anthracycline exposure was 300 milligrams per meter squared for the cases, 140 milligrams per meter squared for controls. And the cases were more likely to have received chest radiation as compared to the controls. And so this is what we found. Here, I'm going to walk you through the slide. Again, on the x-axis is the cumulative anthracycline exposure. On the y-axis, the odds ratio. And what we're looking at in this blue curve is a particular genotype, the CBR3GG, where we see that the risk of developing heart failure is higher if you have the GG genotype as compared to those who have either GA or AA genotype. But what's important to note is that the difference in the risk of heart failure between GG and non-GG genotypes is present only amongst those who received low to moderate doses of exposure between 100 or less than 250 milligrams per meter squared. It is not present in those who receive higher doses of anthracyclines, primarily, we believe, because the high doses of anthracyclines then drive the risk of anthracycline-related exposure, but what's of cardiomyopathy. But what's most important to note is that even at the lowest doses of anthracyclines, people don't escape the development of heart failure if they are carrying the GG genotype. We then took it further and said, let's see whether this particular GG genotype has higher levels of carbonyl reductase activity in the tissues, and yes, indeed it does, and this was in the liver tissue where it's metabolized. Let's now see where it fits in. This is where it fits in our framework. Carbonyl reductase 3 results in the alcohol moiety being generated, which results in myocyte apoptosis. We then also examined GSDM1 null variant and anthracycline-related cardiomyopathy. Now, we all know that GSDs are responsible for detoxifying a variety of drugs, including anthracyclines. And so if you have the null variant, the hypothesis would be that there would be an excess of anthracyclines hanging around causing toxicity. And indeed, we found that those who carried the null variant were at a threefold higher risk of cardiotoxicity as compared to those who did not carry the null variant. Took it on to look at the GSDM1 gene expression, and here in the gray bars are those of the cases, and the pink bars are the expression levels in the controls, and we find that in the large majority of patients, the expression was lower, much lower, almost absent for the cases. We then generated human iPSC cardiomyocytes, the induced pluripotent stem cell cardiomyocytes, in patients who had no toxicity versus those who had toxicity as a result of doxorubicin. And we find indeed that the GSDM1 levels are lower, the expression levels are lower in those with toxicity as compared to those without toxicity. Now let's look at carefully curated SNP arrays. Here, the reason for looking at this was that Saro Armenian led the publication at City of Hope when he looked at the risk of developing heart failure in BMT survivors. And he showed that those who had high-dose anthracyclines were at a 10-fold higher risk of developing cardiomyopathy as compared to those who didn't have anthracyclines. You added hypertension to the mix, the risk increased tremendously. You added diabetes mellitus to the mix. Again, the risk was much higher as compared to when you had only anthracycline exposure. This led us to examining the IVC cardiovascular SNP array. Now, this is a carefully curated, prioritized list of about 2,100 candidate genes. It is about 50,000 SNPs. They are likely to be involved in cardiovascular disorders. So these particular experts prioritize this list of 2,100 candidate genes. Again, the demographics of this population, the only difference being from the previous population that we restricted it. So about 6 years of age, 19 years at the time of diagnosis of either heart failure or at the time of study participation, but all of these individuals were non-Hispanic whites. Again, matched case series in terms of primary cancer diagnosis and higher doses of anthracycline exposures and much more likely to have received just radiation. So here what we find is a particular SNP on gene HAS3, hyaluronic acid synthase 3, fairly common. And what it does is that there's a significant gene environment interaction, such that those who carry the GG genotype, there's absolutely no increase in risk, no matter what the dose of anthracyclines. Those who carry the GA genotype, there's a modest increase in risk. But those who carry the AA genotype, there's a high risk of developing heart failure, and the separation occurs about 250 milligrams per meter squared. We replicated this successfully in an independent population of both whites and non-whites, and then turned our attention to do functional analysis. Now, for this, we took heart samples that were procured from the National Disease Research Interchange, where HAS3 had been genotyped in these heart samples, and we then looked at the messenger RNA levels in these heart samples. And what we find is that those who are at high risk have lower levels of the AA genotype as compared to those who are at low risk, and of the expression of the of hyaluronic acid. So where does this fit into the model? What we find is that HAS3 produces hyaluronic acid, and hyaluronic acid has high antioxidant activities and possibly helps by reducing the reactive oxygen species. But as I had shown in my previous slide, those who are at high risk of developing cardiomyopathy have lower expression of HAS3, resulting in lower production of hyaluronic acid and therefore higher levels of reactive oxygen species. We then turned our attention to agnostic genome-wide association studies. And here, again, I'm going to show you it's the same study population. Again, we are looking at young kids at diagnosis, about 18 to 20 years of age at study participation, and then all non-Hispanic whites. Same story in terms of matched samples by primary cancer diagnosis, higher levels of anthracycline exposure amongst cases, and a higher prevalence of those who had received just radiation. In this particular study, we used an older version of the Illumina Human Omni bead chip in order to do a genome-wide association study, about 500,000 autosomal SNPs. And what we find is that a particular SNP on SELF4 gene that shows evidence of gene-environment interaction. And this is what it does. In the discovery, we find that those who have the AA genotype, no increase in risk with anthracycline dose. Those who have the GA genotype, again, no increase in risk with dose, but those who carry the GG genotype of the SELF4 gene SNP have a much higher risk of developing cardiomyopathy. Again, the separation is around 200 to 250 milligrams per meter squared. We replicated it successfully. We then said, how does SELF4 gene work? So the SELF4 protein, it regulates the pre-mRNA alternative splicing of TNNT2 gene during embryonic development. Now, TNNT2 splicing variants are expressed in the embryonic hearts, but they're mostly absent from the mRNAs in the adult hearts. What does TNNT2 do? We know that it encodes for the cardiac troponin T, and we all are familiar with CTNT. It's located on the striated muscles. It regulates muscle contraction in response to changes in intracellular calcium concentrations. CTNT is a well-established biomarker of cardiac injury, and levels increase soon after anthracycline chemotherapy. So going back to SELF4, if we did have persistent expression of the embryonic TNNT2, in the adult cardiac muscle, in addition to the adult variant, we would have the coexistence of these two variants, and this would result in a temporally split myofilament response in response to the rising calcium levels, and this would decrease the ventricular pumping inefficiency. Indeed, in patients who have de novo dilated cardiomyopathy, there is evidence of coexistence of two or more TNNT2 splicing variants. So I apologize for the animations in this because it gives away the answer. But the question that we asked was that is the SELF4 SNP that we identified, is that status associated with expression of more than one TNNT2 variant in myocardial tissue? We turned again our attention to obtaining heart samples, and we genotyped them. And we looked to see if the embryonic splicing variants of TNNT2 were found in, if they varied by the genotype. So what we find is that amongst those who are at low risk of developing heart failure, if they carry the AA genotype, there is no embryonic splicing variant. Those who have the GA genotype, 62% of them carried the embryonic splicing variant, whereas those who had the GG genotype, 91% of them carried the embryonic splicing variant. And we did believe then that the embryonic TNNT2 variant was more likely to coexist with the adult variant amongst those who carried the GG genotype for SELF4. And this is how it would fit into our model, where self-mediated alternative splicing of TNNT2 would result in the coexistence of more than one isoform of TNNT2, and this would result in inefficient myocardial contractility, resulting in heart failure. Now, others and we have also identified other genotypes, and this is where they fit into the model. And I'm showing you all of these here. And this then has helped us in identifying individuals at the highest risk. Indeed, 87 SNPs have been published thus far. And a previous study conducted by Vischer in Canada used multiple variants, and they combined them into a single prediction model and classified patients into 3 risk groups: low risk, intermediate risk, and high risk, clearly differentiating from each other. We also did the same thing, and we had a more comprehensive approach in identifying or curating the SNPs that are published thus far. And then we looked at creating a risk prediction model in a training set and then 2 test sets. and these are our findings. The clinical model had an AUC of 0.81. The clinical plus genetic model had an AUC of 0.88. The replication in CCSS showed that they overlapped with each other, primarily because the CCSS population had heart failure developing at a much later time point than the COG population. And then we looked at it in the BMT survivor study population, again showing that there is a difference between the two curves. And this is shown here in this particular study, 0.81, 0.88 for COG, 0.64, 0.72 for BMT survivor study. We couldn't differentiate between the CCSS, but when we restricted the CCSF with a shorter period of follow-up and those who didn't have cardiovascular risk factors, we find that there is a 5 percentage point difference in the AUC between the clinical model and the clinical plus genetic model. So then let's talk about screening of high-risk populations. And here I will share with you how we had looked at this particular, how we screen for cardiomyopathy using the COG long-term follow-up guidelines for survivors of childhood, adolescent, and young adult cancers. This is a page out of our guidelines. And what I show here is that within this particular page are the guidelines, which I have blown up here for you, which take into consideration the anthracycline dose, the radiation dose, and the recommended frequency of the echocardiograms for these patients. Finally, in this particular piece of the study, the risk reduction in high-risk populations. This is a study which is being led by Saro, Armenian. The gaps in knowledge were that there were no clear recommendations for secondary prevention in asymptomatic anthracycline-exposed childhood cancer survivors who had preserved ejection fraction. Again, we did not know what pharmacological agent to choose, and carvedilol was identified as a more effective option as compared to enalapril, and carvedilol is well tolerated in children and adolescents. The third question at hand was the timing of intervention. And here, Saro leaned on the Duchenne muscular dystrophy literature, which suggests that the earlier the intervention, the more likely you are to improve the overall 10-year survival, and hence bringing it back to applying this particular intervention in patients with preserved ejection fraction. So this study is currently ongoing. He's taken survivors of childhood cancer treated with anthracyclines, and he's randomizing them double-blinded, placebo-controlled into carvedilol or a placebo, and looking at certain endpoints, which are biomarkers in terms of echocardiographic as well as serological biomarkers. He's performing echocardiograms prior to randomization at 1 year and 2 years following randomization. I want to take this now to the subsequent neoplasms. And here, I'm going to talk about second brain tumors. Second brain tumors, our childhood cancer survivors are at a 10-fold higher risk of developing histologically distinct subsequent brain tumors. These are mainly in the form of gliomas and meningiomas, and they have significant morbidity and mortality. We all know that the 5-year survival for secondary gliomas is less than 20%, and the meningiomas often carry a significant amount of morbidity. Now, the risk factors are exposure to cranial radiation, and then the risk is especially increased after exposure at a very young age. The risk demonstrates a linear relationship. Here we show one for meningioma and for glioma. And then, again, as I had shown for the cardiomyopathy, if you cut the dose of radiation at about 2400 centigrade, you see that several patients develop brain tumors at lower doses, and several individuals escape the development of brain tumors at higher doses. Again, we were looking at the role of genetic susceptibility, and here we used a different approach. We went and curated a set of genes which had been previously published to be associated with adult onset de novo brain tumors. And this is what we found, that adjusting for age at diagnosis, gender, race, ethnicity, and exposure to cranial radiation, that we had at least 6 candidate SNPs that showed significant association with the development of radiation-related brain tumors. We replicated these, and again, what we find is that all of these genes are involved with either DNA repair or DNA damage response. And so this is where we think we fit in this model. Patients get exposed to radiation therapy. Radiation results in a fair amount of mutational burden. Those who have an efficient DNA repair mechanism respond well to that mutational burden, clearing it up so that the brain then goes back to the pre-radiation model. However, if you have aberrant DNA repair, you can develop specific genetic lesions, and these then can go on to result in clonal hematopoiesis and clonal expansion and result in subsequent brain tumors. Now, we use these to identify our high-risk population. This was, again, published in the Journal of Clinical Oncology, where we show that the base model, which has only age and sex, has an AUC of 0.59. The genetic model, including all of these genetic variants, has an AUC of 0.71. The clinical model by itself has an AUC of 0.73, but the final model has an AUC of 0.81. And the replication of the case control set again showed that there was a clinical AUC of 73%, and the AUC of the final model was 89%. Can we reduce the risk of second cancers? And here I'm showing you this is in the setting of radiation-induced brain tumors. Now, we know that radiation-related breast cancer increases as a function of age, and we also know that radiation increases the risk of breast cancer. And I'm sorry for the animations which got lost here, but there's a linear relationship in the development of breast cancer with radiation dose. And it's important to note that the 19% of the cumulative incidence of breast cancer by age 45 is similar to that observed in BRCA mutation carriers. We also know that those who receive a much higher dose of ovarian radiation have a lower risk of developing breast cancer as compared to those who receive a lower dose of ovarian radiation. And this suggests that the endogenous estrogens modify breast cancer risk. And so it then follows that estrogen blocking intervention could be expected to prevent radiation-induced breast cancer in survivors. What are the risk reduction strategies for radiation-related breast cancer? These include surgical interventions, such as prophylactic bilateral mastectomy, but this is not an option for all women. Bilateral oophorectomy is associated with several risk factors. There are certain pharmacological interventions, such as tamoxifen, which is efficacious both in pre- and postmenopausal women, as well as other aromatase inhibitors, but they are available right now only in the postmenopausal setting, thus suggesting that for us, the only option that was available was tamoxifen. And so, given that the latency between radiation and subsequent development of breast cancer is at least 8 years, we need to rely on established biomarkers. Mammographic breast density indeed is one such marker. Others include Ki67, as well as serum markers, plasma markers of IGF-1 and IGF-BP3 levels. Now, tamoxifen is associated with a decrease in mammographic breast density after 1 to 2 years. It precedes clinical endpoints seen at this time point after about 5 years. Now, tamoxifen at the regular dose is associated with a variety of, not so malignant, but malignant side effects. And the low-dose tamoxifen has recently been shown to decrease the risk of breast cancer and without the adverse events associated with a standard dose. So we did a study. We took survivors of childhood or adolescent young adult cancer treated with chest radiation, and we took it forward to randomize them into low-dose tamoxifen for 2 years or placebo, double-blinded and randomized. And the endpoint was mammographic breast density. We looked at histologic markers and also circulating biomarkers. And this is where we obtained our samples prior to randomization at 1 year and 2 years. These are the findings from this study. We found that indeed low-dose tamoxifen resulted in a reduction in the mammographic dense area, and as did it for serum IGF-1 levels. And this is currently under review. These findings are currently under review. We then said, how do we screen for high-risk individuals? Again, going back to the Children's Oncology Group long-term follow-up guidelines. And here's the page out of the long-term follow-up guidelines where you can see that when you blow up these findings, you see that there is the recommendation for mammograms beginning 8 years after radiation or at age 25, whichever occurs first, alternating with breast MRI also annually, beginning at the same time point. I have about 6 minutes left, and I do want to cover one more topic, which is actually pretty interesting. Here we're looking at therapy-related leukemia. If you look at the years since transplant, what you find is that those who've received autologous transplant for lymphoma have an increasing incidence of therapy-related leukemia, which then plateaus out after this, about 15 years. But it's unfortunately associated with high fatality. So we conducted a prospective longitudinal study in patients undergoing autologous BMT for lymphoma. We collected samples prior to transplant, which is bone marrow and peripheral blood. We collected their stem cell product at transplant, and then bone marrow and peripheral blood at all of these time points up to 10 years in order to understand the pathogenesis and to predict the risk of developing therapy-related leukemia. We followed this model. We said that there would be genotoxic insult in terms of therapeutic exposures, that in the face of genetic susceptibility would result in acquisition of mutations. BMT is associated with significant proliferative stress, and that combined with genomic instability would result in clonal hematopoiesis, cytogenetic abnormalities, and then would result in clinical and morphological MDS. I'm going to show you examples of some of these pieces talking about genetic susceptibility. We looked to see, we took this particular study design, we collected their peripheral blood stem cells, banked them, and followed patients to the development of therapy-related leukemia. There were some who did develop therapy-related leukemia, some who didn't. We went back and retrieved their peripheral blood stem cell products and then looked at differential gene expression and found that indeed the changes in gene expression were associated with development of therapy-related leukemia, and these could be identified in the CD34 positive cells from the peripheral blood stem cells several years before the development of therapy-related leukemia. This allowed us to create a gene signature, which had a specificity of about 95% and a sensitivity of about 87%. Let's talk about genomic instability. We used telomere length as a marker of genomic instability. We measured it in the myeloid cell subfraction, and we find that those who are controls show no evidence of attrition of telomere length, whereas those who are cases show a progressive decline in telomere length. And in fact, this happens several months before the development of therapy-related leukemia. Here we are with clonal hematopoiesis. So first of all, what is CHIP? Clonal hematopoiesis of indeterminate potential is the presence of a somatic mutation in a leukemia-associated driver gene that occurs at a variant allele frequency of 2% or greater. It has to be accompanied by the absence of peripheral blood cytopenia, and there has to be exclusion of hematopoietic neoplasms as a causal underlying condition. Ben Ebert and his group from Boston have shown clearly that as you age, you are more likely to carry these CHIP mutations. And these are the three most common types of CHIP mutations. We looked to see whether CHIP would be found in the peripheral blood stem cell product, and could this predict the development of therapy-related leukemia? And indeed, we did. We found that those who carried the CHIP mutation in their stem cell product were much more likely to develop therapy-related leukemias compared to those who didn't. And again, the overall survival was lower amongst those who had CHIP as compared to those who didn't. The same was true for event-free survival. Have we modified therapeutic exposures? And when here we talk about we, we're talking about the royal we, the field of pediatric oncology. And yes, indeed, we have. There has been a reduction in the dose of radiation and field of radiation, of chest radiation, a reduction in dose of cranial radiation, reduction in dose of anthracycline. What has this done? This was a landmark paper from Childhood Cancer Survivor Study, which shows that there has indeed been a reduction in late mortality among 5-year survivors of childhood cancer. Looking at deaths from any cause, this is the cumulative mortality in the 1970s, the 80s, the 90s. If you look at deaths from health-related causes, 1970s, 80s, and 90s. This is the good news we want to end on. However, are we there yet? Are we curing every child? Are we making sure that they live for as long as the non-cancer population? Not yet. But we are solidly on the right path. I want to acknowledge my funding agencies. I want to acknowledge the team in Alabama, as well as outside. And I want to acknowledge the patients and their families. Thank them deeply because these studies would not have been possible without them. And I want to end my talk here. Thank you very much.
Thank you so much. This is Suzanne again. I'm going to start reading through the chat questions. And if your question is asked, feel free to unmute and you can continue the conversation. From Dr. Baker, should CB3 genotyping or IBC SNP array or other be incorporated into treatment decisions for patients at the time of diagnosis, or perhaps utilized to determine monitoring recommendations during long-term follow-up?
Scott, it seems like I sent you a $10 bill and wrote this question for you, and I'm answering that now. I wish I were there so I could see you all when I was answering these questions. Yes, indeed. What we're doing right now, Scott, is two things. First, when I presented all of these studies, what I haven't told you is that we did these studies in cancer survivors. So there was always a survival bias, right? It's only the survivors who we collected the genetic information from and then looked to see whether there was an association with a genetic genotype. Now, could there be an association with a particular gene which resulted both in high fatality and cardiac disease, and those patients were lost at an earlier time point and never made it into the survivorship population? Yes, indeed, that is a possibility. But right now, through a funding mechanism and through the deep generosity of COG, I have been able to collect samples at baseline from diagnosis, and I'm testing all of these particular SNPs at diagnosis in order to see whether there is an association and whether there's also an association with relapse risk. In the meantime, we're also developing a diagnostic assay. We've submitted it through the SBIR mechanism to the NCI, and our hope is that if both of these come true and the stars are aligned, we will have a diagnostic assay which we could apply at diagnosis of childhood cancer in order to determine who is at high risk and who's not. Thank you.
That's great. Thank you.
Thanks.
Okay, and then from Dr. O, I've always thought probably there were some anti-cancer medication combinations that have synergistic toxicity effects. Have you looked at whether any specific drugs in combination with anthracycline are associated with higher levels of cardiotoxicity?
Right. So thus far, when we have and others have examined the combination of anthracyclines with other cancer drugs, the only other cancer drugs which emerge with some amount of an added effect is cyclophosphamide or alkylating agents, but it's not a major effect. The major effect arises from the combination of anthracyclines with chest radiation, and that definitely elevates the risk. The other major effect emerges from the development of cardiovascular risk factors, which are discussed, the diabetes and hypertension, which significantly elevate the risk. I hope this answers the question.
Thanks. And then again, let's see, Dr. Baker, what we know is related to old therapies. How can we prospectively study new agents, targeted therapies, et cetera, so we don't have to wait 20 years to find out what their late effects are going to be?
Right. And again, that's a great question. And I know Eric is in the audience, and he would probably be better suited to answering that question. The only way that we can study the new agents in a proactive fashion and not have to wait for 20 years is to do two things. One, establish large enough cohorts so that we can study them right from the beginning. And the second is to have well-established biomarkers that we are very confident in terms of saying that these biomarkers reflect that these patients are at a high risk of developing cardiomyopathy, say. Those would be the things that would be needed, and somebody who's younger than me needs to mount those efforts.
Thank you.
Mm-hmm.
And I'll wait a few minutes to see if somebody else is typing. But in the meantime, I will just preemptively say thank you so much for being here. Stay safe in the hurricane. And we really appreciate your willingness to try this out by WebEx. We know that this is not the ideal situation. We're looking forward to getting back to hosting everybody in person. So thanks so much for doing this. Yes. Can't come fast enough. And thanks to Dr. Hawkins for hosting the Chard lecture. We really appreciate you. There are a lot of people on the chat also saying thank you so much to you. And I'll just be quiet for 30 more seconds to see if there's any other questions, and then I'll let everybody go.
Well, I am so deeply appreciative of being invited for this lectureship. Honored. And it would have been such a good opportunity to be in Seattle, meet my friends there. We'll do it another time.
Yeah, definitely.
Yes.
Great. Well, thanks so much, everybody. We appreciate you spending your Thursday morning with us, and we'll see you all next week. Thank you.
Bye.
Thanks.
Okay, bye, everybody. Thanks again.
Bye.